Okay, good afternoon, everyone, and thank you for joining us for the Medical Board of California Midwifery Advisory Council meeting. This meeting is being conducted via WebEx. Public comments will be heard for each agenda item for individuals wishing to speak. In order to be ready for public comment, we ask that you please ensure your comments can be heard clearly by being connected to the audio of this meeting through the proper method. If you are having difficulty hearing the audio of this meeting, it may be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application, and then select Switch Audio. You'll be presented with a telephone number, access code, and attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you're having audio problems with your device, this will allow you to still participate and hear the audio of the meeting. Please see the instructions on how to connect link on the last page of the meeting agenda for step-by-step WebEx instructions, including screenshots. Thank you, Ms. Weisner. You can now start the meeting.
Hi, good afternoon, everyone. I would like to welcome you to the Midwifery Advisory Council meeting. It is 8:12 here. It is 1:12 p.m. And can I please have a call to order and a roll call and the establishment of a quorum? Do we have a quorum? Have we met quorum?
Yes.
Great. Wonderful. Thank you. Once again, my name is Madeline Weisner, and I am the chair of this advisory council. Since this meeting is being conducted via WebEx, I will ask all members and speakers to announce themselves by name before speaking for clarity of the official record. All MAC members are able to unmute themselves to speak during the meeting. Please place yourself back on mute when you're not speaking to reduce background noise for all the participants. Following such online meeting etiquette will ensure the best audio quality for everyone. Do we need a roll call before I keep going?
Yes, I can take the roll call. Faith
Awesome,
Freeman.
thank you.
Faith Freeman.
Present.
Dr. Kenneth James.
Here.
Tamara Robertson.
Present.
Mason Wilson Tanev. And Madeline Weisner. Thank you. We have a quorum.
Awesome. Thank you for that. As a reminder, just during each call for comments from MAC members and speakers, we want to ensure that all comments can be accommodated and are heard before proceeding with the agenda. During each agenda item, the host moderating this WebEx event will activate the Q&A and hand-raising features of WebEx and will ask anyone wishing to make a public comment to indicate so by replying yes in the Q&A window or by using the hand-raising features. The host will then call on individuals who indicated they wish to make public comments by name. When called upon, the host will unmute the microphone of the individual and they'll be able to make their public comment. After the comment, the individual will be placed back on mute. Please see the agenda for WebEx instructions on how to connect from the link on the agenda and additional instructions. The board's IT staff will assist me with receiving the public comments via WebEx during this meeting. MAC members, as a reminder, during today's meeting, any items requiring a vote will be done by roll call vote. This means that once a motion is made and seconded, Ms. Moriarty will call each of the names individually to request our vote. I would like to now call the meeting to order and ask that Ms. Moriarty call herself awesome because we already called the roll. Thank you. Moving to agenda item 2, public comments on items not on the agenda. Are there any public comments today?
Thank you. And as Ms. Weisner said, if you'd like to make a public comment, please do so by using the hand-raising feature there in the WebEx window, or you can use the Q&A window. No need to type your entire question. You just have to type anything. Yes, preferably something short. We'll queue you up. You can make your public comment. Give everyone a few seconds there. I just saw Ms. Wilson-Tanev join as well. Hey, Ms. Weiser, I'm not seeing any requests at this time.
Interesting. Okay. Shall we move to agenda item number 3, which is approval of the minutes from the May 30th, 2024 Midwifery Advisory Council meeting? I had a correction that I would like to be made. It says that I was present and did things on the final items in the agenda, and I did not. Ms. Freeman did those things, so that is a correction I would like, please. Are there any other additions or corrections to the May MAC meeting minutes from the members?
Ms. Weisner, you're talking about under agenda item 10.
Yes,
Thank you very much. I will correct that.
thank you.
Would someone like to make a motion to approve with those corrections?
I'll approve. Or motion to approve.
Motion? I'll second.
Take the roll call vote.
Ask for public comments.
Is there any public comment on this approval of the meeting minutes?
If anyone would like to make a public comment, please use the hand raising feature there in WebEx, or you can just type anything in that Q&A window and we'll call upon you. A few seconds here to queue up. Not seeing any requests at this time.
Ms. Moriarty, please perform the roll call vote.
Faith Freeman,
Yes.
Dr. Kenneth James,
Here.
Tamara Robertson,
Yes.
Mason Wilson-Tanev,
Present. I'm sorry. I'm just can people indicate that they're actually approving the minutes?
Sorry, approve.
Dr. James. Okay.
Yes, approved.
thank you.
Okay.
Madeline Weisner. Thank you.
The May 2024 MAC meeting minutes are approved. Thank you. Moving to agenda item number 4. This will be somewhat of a long report, so I appreciate your time and your patience as I deliver this, and I would like to remind you that you can grab a cup of water, cup of tea, whatever you need. And I really just want to express that as the chair of the Midwifery Advisory Council, it's my pleasure to present this report today, even though it might feel somewhat grim. It's going to be long, and I am a slow talker, so bear with me if you can, and if you can't, that's fine too. Like the rest of the meeting, it is being recorded, and I'm sure there will also be a greatest hits type summary available in the meeting minutes. As a reminder, the MAC is an advisory council tasked to represent licensed midwives and midwifery consumers in communications to the Medical Board of California. The MAC is comprised of 3 licensed midwives, 1 physician and surgeon, and 2 public members, and we currently have 1 vacant seat, which is for a member of the public. The MAC members you see here are not medical board employees. We volunteer to serve and attend the MAC meetings for up to a 3-year term. I'd like to remind everyone here today that the MAC meetings are one of the only pathways given to us by our regulatory body for midwifery stakeholders to speak up and theoretically have that message make it to the medical board and inform how they regulate our profession. We encourage you to do this, and board staff are very helpful in facilitating this at MAC meetings. You've seen them be so patient with us and so patient with members of the public. If you have feelings about the medical board only offering us an afternoon meeting every few months to talk through all of the issues facing licensed midwives and our clients in California, I do think that there's probably some good information there. So the first thing I'd like to do today in this report is to just refresh our legislative memory a bit. Midwives have been attending childbirth since like the Paleolithic era, like forever and ever. But certainly in California, you know, the state was founded in 1850 and midwives were part of the community at that time. In 1917, AB 1375 was signed into law. This bill licensed and regulated midwives under the Board of Medical Examiners and established midwifery as an independent profession that was distinct from obstetrics and also distinct from nursing. Midwives had by now already faced decades of overtly racist, xenophobic, classist campaigns from the physician lobby who represented obvious conflicting material and ideological interests. These propaganda campaigns aimed to discredit midwives and their highly respected positions in their communities. At this time, practicing midwives in California were predominantly poor and working class and were often born outside the US, and many were trained as midwives outside the US as well. Midwifery regulation in the form of a midwifery practice certificate was added to B&P 20 years later in 1937. And then came World War II, and with it, California was rapidly industrialized. This gave way to the consolidation of health services and an abrupt rise in physician-staffed maternity hospitals and health systems. Many of these maternity care providers that were thriving in California around that time, such as Sutter Maternity Hospital and Kaiser Oakland, still actually employ the majority of maternity care workforce in their regions. And now, additionally, these entities have roles in the payer landscape. In 1942, entire communities of Japanese Americans, Italian Americans, and German Americans were moved to concentration camps in the middle of nowhere in California. This mass incarceration of innocent people included many women, obviously, and also included midwives. Midwives were prohibited from working during their internment. So we had this mass imprisonment of the midwifery workforce, not for midwifery, but as an effect. And this coincided with a massive shift to industrialized, facility-based, physician-managed maternity care, which functioned parallel to an ongoing campaign to discredit midwives and midwifery and a political strategy to completely stop the training and credentialing of new midwives. So once most of the midwives were not practicing because they were interned, the line from the legislature and from the Board of Medical Examiners was that there weren't any midwives anyway, and those who remained were mostly functioning as nurses, not midwives. And so together they made a plan not to withdraw licenses from the existing handful of credentialed and practicing midwives, but instead the plan was, for one, to just let nature take its course. Let me explain. All of the remaining practicing midwives at that time were over 70 years old. And at this point, they would retire or die soon. So in 1949, California's Midwifery Practice Act was repealed by the legislature via SB 966, which meant no new certification of midwives could take place. This was a near complete eradication of professional midwifery by organized medicine with the support from the California legislature. And this did not help the ongoing cultural shift away from family-centered and community-centered toward industry, toward new technologies, and toward an institutionalized model of maternity care. Midwives did not practice legally again in California until 1974, when nurse midwifery was defined in statute, and the state began licensing certified nurse midwives. Public demand for home birth and midwifery care continued over the subsequent decades, and midwives kept attending to families at home. The midwives who did continue practicing, who continued serving families, attending home births, were reported usually by hospitals or doctors and prosecuted. California led the nation in the criminal prosecution of unlicensed practitioners providing home birth care. However, the persistent demand for the midwifery model and the very committed organizing by midwives and clients resulted in the Licensed Midwifery Practice Act, LMPA, in 1993. This act reinstated the licensure of midwives in California by assigning regulatory and disciplinary authority to the medical board. This law required licensed midwives to practice under the supervision of a physician. 20 years later, the signing of AB 1308 amended BNP to remove physician supervision for licensed midwives, as even the legislature was willing to admit this requirement was functionally unobtainable. The language altered the legal scope of practice for licensed midwives and required the promulgation of new regulations. These regs would provide a list of criteria that would trigger a consultation with or a transfer of care to a physician. Certain components of care, such as hospital transfer, were required in the statute to be performed by a midwife regardless of a patient's consent, and clients would now be required to consult with a physician in the event that their care fell outside the still extremely subjective definition of normal pregnancy. A definition which, by the way, is not aligned with scope of midwifery care that California licensed midwives are trained and equipped to provide. It's much more restrictive and incongruent with the midwifery model in many circumstances. Our statute continues to restrict our ability to provide continuity of care to our clients, which is a cornerstone to midwifery practice worldwide, and poses requirements to LM care that many would argue are mutually exclusive to the basic principles of professional ethics. So now that we have that information, where does that put LMs now? BNP, as it's written, continues to give the medical board and its designees authority over members of a competing profession that they have oppressed, marginalized, and attempted to eliminate politically, legislatively, financially, over and over. BNP, as it's written, features an outmoded, chaotic, and dangerous definition of midwifery that's not in line with international standards of midwifery. It does not reflect the training licensed midwives receive or the care these midwives should ethically and professionally be providing. This language clearly functions as more of a Rorschach for individuals who are tasked to interpret it. The words disease, condition, significant, and even the word likely are all acutely contentious terms in midwifery and in medicine, and will produce different images for each individual who gazes upon them. If you line up 10 licensed midwives, 10 doctors, 10 malpractice lawyers, and 10 insurance plan medical directors, you will get wildly different projections from these words. We've seen this play out repeatedly since AB 1308 was signed. Investigation and enforcement processes at the medical board continue to routinely utilize underground regulations, which is understandable given the dearth of clear guidance and statute. Understandable and also completely inexcusable in terms of investigation and enforcement. We all have a right to access the rules that can and will be used against us in disciplinary matters, as midwifery licensure is expected to be in agreement to those rules. California is only one of 4 states in the US that continues to regulate midwives under the outmoded Board of Medicine model. Other states have recognized the conflicts of interest and potential for regulatory capture inherent in this model, which creates unnecessary barriers to access, stymies rulemaking, and certainly threatens public health and safety. The practice of midwifery, on another hand, is more financially precarious than ever within California's maternity care payment system. Midwives in California are experiencing a skyrocketing cost of living and record expenses for supplies, life-saving medications, and other overhead required to practice safely. Malpractice insurance premiums for licensed midwives required for Medi-Cal providers are currently held by a duopoly. Most clients, also facing all of these cost of living increases that far outpace their own wages, cannot afford to pay for their care, what midwives need to receive to sustain their businesses. Those who can access private insurance coverage through their employers or through a marketplace find that although they are financially burdened by their insurance premiums, their insurance will not cover their midwife. So to restate that, insurers are receiving payments for premiums from patients and their employers for maternity care coverage, but licensed midwife providers are not seeing those payments because those payments are being extracted as profit for the insurance company. Licensed midwives have virtually no worker professions. An LM is on call for their clients and will show up 24 hours a day, 7 days a week to perform some of the most grueling and thankless work imaginable. If a patient or a client goes to the hospital by means of an appropriate, safe transfer, midwives have an even harder time billing insurance or securing their fees from clients directly. There's no OSHA for unsafe conditions for midwives, and midwives are forced to risk their personal safety and well-being for this job regularly because of the very nature of the job. In the face of ongoing scrutiny from their professional colleagues and complete neglect from their regulating board, some midwives are quitting midwifery. They're going back to school. There are cases in which they have to start over completely because their midwifery education program is not transferable to another degree. They're getting jobs in unrelated fields. They're moving out of state or out of the country. This is all occurring at a time when California, like the rest of the nation, is experiencing what have proven to be catastrophic gaps in maternity care. So this brings me to the ongoing maternity unit closures. Since AB 1308 was signed, nearly 50 hospitals in California have either shut down or suspended their labor and delivery departments, with 27 of these closures occurring in the last 3 years alone. These closures are predominantly affecting rural areas and have a dozen California counties without any hospitals providing maternity services. Freestanding birth centers that are midwife run are also closing faster than they are opening. I know of at least 10 California centers that have stopped providing services in the last 2 years. Licensed midwives in many California regions are the only maternity care providers at all. And even with a drastic increase of this workforce, there are no real systems in place to ensure safe transfer for people who reasonably fall outside the care of licensed midwives. The closures of maternity units and even standby maternity services in rural hospitals means that LMs have no way to uphold their requirements under B&P to consult or transfer under certain circumstances. And they're faced with the option to completely discontinue their own practices, to relocate, or to abandon clients individually if their care is outside their legal scope. Licensed midwives overwhelmingly follow their ethical principles in these situations and do their absolute best to ensure safety for their clients and continuity of care. Apart from licensed midwives, what populations are being impacted by these maternity unit closures? Simply put, everyone, primarily poor and working class communities, exacerbating existing maternal newborn health disparities, especially for Medi-Cal beneficiaries. But private insurance, families with private insurance and uninsured families, families enrolled in health share plans, they're also subject to this crisis, which is why I think it's finally beginning to get some airplay. The spread of maternity care deserts comes amid a rising mortality rate for mothers, where pregnancy-related deaths reached a 10-year peak in 2020, with nearly 60% of these deaths being categorized as preventable. Families receiving midwifery care are not able to safely transition from medical care to midwifery care, or from midwifery care to medical care. And these transitions are often not able to be timely based on payment structures and a shortage of midwifery providers, as well as obstetric providers. Midwives also feel their livelihoods are threatened when they provide care to certain women who may not even receive better care or safer care in a hospital, if there is a hospital at all. Hospital birth that is the result of institutional coercion is not safe childbirth. Families who are told they're outside the criteria of normal birth, who have no geographic access to any maternity hospital where they may feel safe birthing, are birthing alone without a skilled attendant. Communities statewide are seeing unattended birth that is created as a result of this institutional coercion. Midwives who support families who have no realistic choice but to birth unattended are facing increasing scrutiny from the medical board. So as it stands in California, consumers who desire midwifery care and may benefit from it do not have a reliable pathway by which they can access it. And the same can honestly be said for OB care, nurse midwifery care, primary care, mental health care, social work, blah, 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 housing, all of it. Even with this barrage of challenges faced by licensed midwives, midwives are showing up. They're showing up to care for clients and for the protection of midwifery. We'll be talking about licensure statistics today and hopefully get a more clear picture of what practicing midwives are doing. And I hope that we can get some public comment at that time. That'll be its own agenda item though. As far as interdisciplinary collaboration goes, licensed midwives and nurse midwives in California have been collaborating more than ever. We've reminded ourselves that we have common ground and solidarity as midwives. And we're clear that the only pathway forward is on behalf of midwifery and to center the families that we serve and the entire midwifery community. This intentional collaboration has brought LM participation to landmark projects like the Vaginal Birth Toolkit and the Community Birth Partnership through CMQCC. Incredible pieces of work. Clinical guidelines for California obstetric providers based on evidence and best practice are now inclusive of licensed midwife care, which is huge. Most promising is Midwifery Access California, which is also known as MACA, formerly the Midwifery Learning Collaborative. This is a multidisciplinary organization. It's intentionally innovative and collaborative. It's well facilitated, and it's a group of people that gathers regularly, who are the biggest kind of players in midwifery policy. These people include representation from state midwifery organizations, Department of Healthcare Services, and other state entities, health advocacy organizations, midwifery education, members of the workforce, all of whom we have struggled for years to get into the same room. MACA has produced, among other things, guidance for payers regarding best practices for credentialing and contracting with licensed midwives, as well as California's first alternative payment model that is specific to community midwifery care. This model can and should be replicated by individual midwifery practices, payers, and other health systems who would like a new and midwife-centered payment model. So I'd like for my formal request to the MAC be that a sitting member of the Medical Board of California join MACA or have a designee or designees from board staff to do so. I will not pretend that I know the process for this, but I will state that this is a demand from me as the chair on behalf of licensed midwives and consumers, and the least the medical board can do, given our ongoing regulatory stalemate, is to assist with MACA. The medical board has previously acknowledged and understood the need for a licensed midwife board, and I would like to state for the record that someone from the board participating on MACA would signify the medical board's ongoing support for such a goal to the legislature, who needs to see clearly that everyone is on board with this and that there is a path forward. Further buy-in from the medical board would be extraordinary. So that's really what I'm asking you for today, as well as some discussion among the MAC members and of course the public. This concludes my report today. Thank you for listening. Do we have any conversation from the MAC?
Madeline, may I speak for a moment?
Yeah, of course.
Thank you so much for that historical background and situating licensed midwifery into the context of practice and the deep history of California. That was really wonderful. I very much appreciate that and your clarity. So do I understand you, you're asking for the medical board to join one of the midwifery advocacy organizations, specifically the MACA, to more integrate from, instead of a vertical integration from MACA up into the medical board, to have the medical board integrate in a collaborative way with MACA? That's the request?
Yes, absolutely. MACA, as it currently exists, is a collaboration of a whole bunch of state entities, as well as charitable organizations, individual workers, birth center owners, and the way that it is structured is very horizontal, as you say, and it's very much like all of us in a room together, finding what we agree on and who we know that can make it happen. And it's really incredible. And the medical board is missing from that, which is nuts, considering that each and every licensed midwife has to interact with the medical board at least a little bit, you know? So we need buy-in from our regulatory body, for sure.
I see your point that seems like a real miss for the regulatory body to understand the organizations and the individuals they are in fact regulating. That seems really helpful. Is there anybody on the medical board who you would invite specifically? And do you have a date that you'd like to see this happen by? And is there any follow-up that can, what would next steps be? And then I'll stop from there. Thank you again.
As far as I know, people can join MACA on a rolling basis. and every MACA meeting there are new members, but that might be changing soon just because it seems to be growing. So as far as the date goes, as soon as possible. I do know that the medical board presented the midwifery licensed midwife budget for their program, and that they the program itself funds attorney fees and funds staff. And although I know the medical board already is using that to fulfill its existing functions, I think it's reasonable to demand that a new function come out of that budget, especially because the program itself is under budget. Yeah, did that answer your question? Did anyone else have thoughts? Everyone else fell asleep. That's okay. That's okay. As I said, it'll be recorded.
I just wanted to also say thank you so much for presenting all of that really good background information and kind of bringing everything to a clear focus. So yes, thank you. I don't have any additional questions or comments other than, did you have any specific person, Ms. Wilson Tanev just mentioned it as well, from the medical board that you had in mind, or you feel like that could be a next step of just approaching different members and seeing who may be the best fit or the most interested to join the MACA group?
I think that anyone who interacts with the legislature from the medical board would be important. I also think that anyone who's actually on the medical board would be important. I can also respect that we're part of like a meeting industrial complex at this point, and everyone is really tired of meetings, and I get that, I hear that, but we need some sort of we need our regulatory body to listen to us in a different way and to connect us with a path forward in a different way. The medical board has been supportive of licensed midwives having a midwifery board, but when we approach the legislature about it, you know, the response has been initially positive, but really representative of this like century-long ideology of midwives just not being good enough to be safe. And I would like to see our regulatory body represent us in a different way to the legislature. Not just that we need a board because then they wouldn't have to deal with us, which I get and I also agree with, but that we need a board because licensed midwives should be autonomous practitioners, and there's an inherent conflict of interest of having physicians regulate their competition. So, but I don't, you know, the reason I opened up this report was like an explanation that we're not medical board employees. We don't work for them. We don't, you know, we are privileged to be invited into this space, but at the same time, like, how would they dare not invite us given that they are okay with ruining our ruining our lives, investigating us based on underground regulations, investigating and enforcing that. So who truly holds the power in any of this, you know? All I'm asking is is for someone from the medical board to show up to these meetings, report back to the medical board what consumers are actually struggling with in California in regard to midwifery care. I don't know. I would love to hear from other folks about this though, because yeah. Do we have any public comments, perhaps?
Anyone wishing to make a public comment, please do so by raising your hand here in the WebEx windows or using the Q&A window and just type anything you'd like. A few seconds here. That's why I'm not seeing any requests.
Dang. Well, sounds like we get to move on to agenda item number 5, which is the update on midwifery related legislation from Mr. Bone.
Good afternoon, members. Aaron Bone, the board's Chief of Legislation and Public Affairs. Just have some very brief prepared remarks for today. As you may know, the legislature has wrapped up their main work for this 2-year legislative session, which concluded on August 31st, the constitutional deadline to pass most bills. There are now hundreds of bills approved by the legislature before that deadline, and they are now on the governor's desk awaiting either his signature or his veto. Since my report at the prior MAC meeting, I've continued to monitor bills that were introduced and amended, including those that are, as I mentioned, awaiting action from the governor. During those reviews, I've not identified any legislation that is specifically impacting licensed midwifery. After the upcoming election in November, the legislature will formally kick off their next 2-year session in December, when they will swear in newly elected legislators and begin introducing new bills in earnest starting in January of 2025. And that concludes my comments. I'm happy to attempt to answer any questions. Thank you.
Do we have any questions or comments from MAC members? Sounds like perhaps that is a no. Do we have any public comment?
Anyone wishing to make a public comment, do so by using the hand raising feature or type anything in that Q&A window. Keep you a minute or a few seconds here to queue up. Not seeing any requests, Ms. Weiser.
Okay. I suppose we can move on to agenda item number 6, which is another report from yours truly regarding Medi-Cal related issues. Also a grim report. Fewer than a dozen licensed midwives are actively participating in the Medi-Cal program. Medi-Cal's own database, which is updated like frequently, and you would think would be reliable, is labeling CNMs as LMs and vice versa. So it's a little chaotic. I personally combed through this database over the last week and saw a couple of new names, which was really, really satisfying to see. But I also saw even more names of midwives who are still on the enrollment list, but who have closed their practices or have stopped taking Medi-Cal. Recent research from UCSF highlights critical barriers for Medi-Cal enrolled midwives in California. This is something everybody should be seeing. Despite the rising demand for midwifery care, especially in low-income areas severely impacted by hospital maternity ward closures, midwives face significant obstacles in accessing Medi-Cal reimbursement. These barriers include inadequate rates, astronomical malpractice insurance costs, and procedural misalignments with the managed care plans. The study draws from interviews with 23 midwives across 20 counties in California, and it underscores the urgency of a sweeping reform to Medi-Cal processes to actually support these midwives. We know that more licensed midwives being able to accept Medi-Cal will improve access to perinatal care amidst this maternity care crisis. But as I discussed before, There are a lot of moving parts in this, and simply an increase of midwives taking Medi-Cal will not address maternity care deserts appropriately. The implementation of SB 407, authorizing licensed midwives as providers for the CPSP program under Medi-Cal, is tied to the licensed midwife regulations mandated by AB 1308, which, as I discussed earlier, has not happened yet. Because those regulations don't exist, licensed midwives until recently were not able to qualify to become CPSP providers. After years of concerted teamwork and communication, DHCS designees made the administrative decision for their program to add CPSP codes to the Medi-Cal allowed codes list for LMs in October of last year. They issued guidance to CDPH stating that LMs can enroll as CPSP providers. As of now, no LMs have actually been approved as CPSP providers, and there are clear issues with implementation and communication between DHCS and CDPH and the other relevant entities. Without the ability to become CPSP providers, licensed midwives who run birth centers have been unable to meet this specific requirement to secure alternative birth center licensure from CDPH. I'd like to give a specific shout out again to MACA for really closely chasing this issue. And MACA has also set the stage for what I hope are really meaningful changes in the payment structures for midwives. Primarily, they've released a best practices for credentialing document, and they have very painstakingly created a midwifery payment model that is reflective of the time and labor intensive work that midwives do in caring for clients. It's a replicable model created with the intent of being used by health insurers, but also by individual midwifery practices, birth centers, as a way to itemize a bill for services based on the actual work that has gone into those services. It's really cool. That concludes my Medi-Cal task force report of the day. Do we have any questions or comments about that from the members today?
No questions, just, stating how disheartening it is that it's not a better system and that it's still where it's at as far as improvements and overall function.
True that. Do we have any other comments from the members, or do we have any public comments?
The Q&A feature and the hand raising functions are available. Anyone wishing to make a public comment, please go ahead and use either of those. Give a few more seconds to see if anyone raises. I'm not seeing any requests this time, Ms. Weissner.
Thank you. We can proceed to agenda item number 7, which is the program update from Ms. Moriarty. Please proceed with the program update.
Thank you, Ms. Weissner. Please turn to tab 7A1 of the packet for the midwifery program licensing statistics. In the fourth quarter of fiscal year 2023-2024, the board received 3 new applications, issued 1 new license, and renewed 60 licenses. Please turn to page 7B1. In the fourth quarter of fiscal year 2023-2024, the board received 54 transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives. Please turn to page 7C1. for enforcement statistics for licensed midwives. In the fourth quarter of fiscal year 2023-2024, the board received 13 complaints and referred 3 for investigation. Please turn to page 7C2. In the fourth quarter of fiscal year 2023-2024, the board did not receive any complaints for unlicensed midwives. Please turn to page 7C3 for enforcement statistics for transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives. In the fourth quarter of the 2023-2024 fiscal year, 52 transfer of planned out-of-hospital delivery to hospital reporting forms were received by the board, and 1 was referred for investigation. Please turn to page 7C4. In the fourth quarter of the 2023-2024 fiscal year, the board received 2 transfer of planned out-of-hospital delivery to hospital reporting forms for unlicensed midwives, and none were referred for investigation. Please turn to the 2023 California Licensed Midwife Annual Report Summary. For 2023, there were 604 midwives expected to report. Of those, the Department of Healthcare Access and Information received 457, leaving 147 licensed midwives that did not report. The total number of clients served during this calendar year was 7,444, a decrease of 782 from last year. The number of clients who left care for non-medical reasons was 368, compared to 453 last year, a decrease of 85. 4 sets of multiples were delivered out of hospital. Page 4 indicates the number of planned out-of-hospital births at the onset of labor was 4,958, compared to 5,550 last year, a decrease of 592. And the number of completed births in an out-of-hospital setting was 4,174, compared to 4,697 last year, a decrease of 523. Pages 11, 12, and 13 identify the outcomes per county in which birth, fetal demise, or infant or maternal death occurred. Compared to last year, the number of deaths for fetal demise increased by 3 to a total of 20. The number of infant deaths decreased by 5 to a total of 4. And 1 maternal death was reported compared to 0 last year. Thank you. That concludes my update. Do I have any questions?
Thank you, Ms. Moriarty. Are there any questions or comments, or shall we proceed to public comment?
No questions.
Are there any public comments?
A feature in the hand raising function are available. Anyone wishing to make a public comment, please queue up by doing either of those. Be a few seconds here. Not seeing any requests this time, Ms. Weisner.
Thank you. Moving on to agenda item number 8, discussion and possible action on 2025 Midwifery Advisory Council meeting dates. I learned how to do this date selection. We need to choose. It's like a this or that game for each of those 2 options, and then we will seek comments, and then we will have a motion to approve the full slate of dates selected. So what I'm going to do is I'm going to ask if people have a preference between each set of dates, and then we'll pick the full slate and approve it. Sound good? All right. So does anyone have a preference on January 23rd or January 30th for the January 2025 MAC meeting?
January 23rd.
Cool. Does January 23rd sound good?
Sounds good.
Yes,
Okay. So we shall add that to the slate. April 3rd or April 10th?
No preference.
Cool. Let's do April 3rd, September 11th, or September 18th.
September 11th would be a mild preference.
All right, let's do September, not like do September 11th, but let's do the meeting on September 11th. Okay, so are there any questions or comments from the members? About that?
No questions or comments.
Are there any public comments?
Anyone wishing to make a public comment, you can use the hand raising feature or the Q&A window. Both are available. Give everyone a few seconds to see if anyone queues up. Seeing any requests at this time.
Cool. May I have a motion to approve the dates of January 23rd, April 3rd, and September 11th for next year's meetings?
Motion to approve.
Can we have a second?
Second that.
Ms. Moretti, can you please perform the roll call vote?
Faith Freeman,
Yes.
Dr. Kenneth James,
Approve.
Tamara Robertson,
Approve.
Mason Wilson Tanev,
Yes.
Madeline Weisner.
Sounds like the motion carries.
Thank you.
Very good. Thank you.
Sorry, Ms.
Moving to
Weisner,
agenda-
did you also
Yeah.
say yes?
Yes.
Okay, it must have cut out for me. Thank you.
Oh, sorry. Yeah. Sounds like the motion carries. So everyone mark your calendar. It's going to be a wonderful 2025 for the MAC. Moving to agenda item number 9, future agenda items.
Okay, so
Do-
I'm fairly new to the MAC. I'm still getting used to the flow of this meeting and all of the things. Originally, I had intentions on coming on here to request that we include a discussion on the accessibility and sustainability of midwifery care across the state of California. But you had that presentation. It was very amazing. I'm wondering like how this would work. Like, after your presentation, with you wanting someone to sit with MACA from the board, how as a board do we support that? How do we move that forward? Was the presentation strictly for presentation purposes, or is there something we can do or vote on to kind of move things forward? I guess my question would be. And also, with a future agenda item, what would that look like for us to add that to the agenda? Which would be the discussion of accessibility and sustainability. But we just had a discussion. So I'm just wondering like how this works. And I understand that we need to talk amongst each other with the public. You know, we can't have these side conversations and things like that. So please explain to me.
You know, I scoured Bagley Keene looking for like, what could we do? You know, we're not a government, so we can't like issue a proclamation, even though that would be cool. I don't think we can even like draft a resolution. Ms. Webb knows. Ms. Webb knows these things. But it seems that the communication line is we say things at the MAC, and those things are synthesized into a report, usually by me, usually by someone from the medical board who types it up, and then I read it from the script to the medical board at the medical board meeting. And then the medical board members go like, yeah, sure. And nothing changes. That's how it feels. I don't know what else we can do. I feel like I keep asking and keep getting told that the MAC, is already doing most of what it can do functionally as an advisory council. But the other piece is that we can just talk about it and have it be in the meeting minutes and have it take up enough of the meeting that we can have that be theoretically a part of the chair report that goes to the medical board. I think it's really reasonable to request that an agenda item be a thorough, a scathing indictment of the health system, or a discussion on, seeking input from maybe midwives who are not on the MAC, who are working in California and what they are experiencing as, the people who are truly touching grass with this. I don't know. I'm wondering what you think about that.
Okay. So for a future agenda item, I would like to recommend that we talk to midwives who are in California. About these issues that we're having. And for the sake of meeting minutes, let's just record it. And can there be an opportunity for you to present what you presented to us to the medical board?
I think that would be really great and important. And you should know that the medical board knows this information already. The facts of my...
I just want to remind you that this is to put forward future agenda items, suggested future agenda items. And so you have to be careful of not going too far in the details, because on something that hasn't been agendized, where people could be alerted to the discussion and decide whether to participate. So you can make suggested agenda items, a little bit about what that would entail, but you can't get too far into the details.
Well, thank you. Thanks for the reminder, Ms. Webb.
Yeah.
So it sounds like the idea would be to propose an agenda item that is a presentation as well as a discussion, or maybe even a panel of midwives regarding, the state of midwifery in 2024 in California.
Accessibility and sustainability.
Accessibility and sustainability.
Included. Yes, please.
Yeah, totally. I mean, I would love that. Does anyone else have suggestions or agenda items for the next MAC meeting? I have an agenda item for the next MAC meeting, and it is that it would be discussing the fact that the medical board's enforcement program needs licensed midwives for their medical consultant and expert reviewer programs. And I forgot to talk about it at this MAC meeting. So I would suggest that it be an agenda item for the next MAC meeting, please. Because I don't know how to sneak that in. I'm sorry.
Harry, would it be okay for Ms. Weisner to read the statement regarding medical board needing reviewers, or?
Ms. Weisner, if you chose, you can go back to your president's report.
Just go back in
add
time.
it in, and
you want to hear
and
it
then
again?
invite comments.
Oh, okay.
To include the additional information, since it's helpful for midwives to have experienced midwives serve as consultants and experts.
Sure. Yeah. Okay. Well, let's just wind back the clock a little bit. Take a walk down memory lane to my report from the chair, and what it should have had included was that the medical board's enforcement program has asked me to share that they need licensed midwives for their consultant and expert reviewer programs. This is an opportunity to learn about the types of complaints the medical board receives, provide your expertise in reviewing complaints, and further support the integrity of your profession. The two areas in which licensed midwives may participate are in the central complaint unit, where midwife consultants evaluate quality of care complaints to determine if further investigation is required. And two, in the Health Quality Investigation Unit, HQIU, where expert reviewers provide expert opinions on board cases and testify at administrative hearings. For application and eligibility requirements, you can go to the medical board website at mbc.ca.gov, click on the enforcement tab, and then click the links to medical consultant and expert reviewer programs. You can also call the expert reviewer program at 916-263-2500 or the medical consultant program at 916-263-2502. If you are not interested, but you know someone who may be, please share this information with them. On behalf of the enforcement program, thank you for your consideration. Are there any additional comments from the MAC members on my report?
No comment.
Thanks for letting me do that. Are there any public comments on my report?
Hand-raising feature. No problem. The hand-raising feature in the Q&A window are open. Anyone wishing to make a public comment, request a agenda item or on the additional information from the chair's report, please go ahead and queue up now. Give everyone a few seconds. Okay, I'm not seeing any requests at this time.
Thank you. Let us return to agenda item number 9, which was future agenda items. Did we have any additional agenda items from members for the next MAC meeting?
Yes, I would like to try again to make an audiology presentation I was not able to do this time around. So I'd like to add that to our next meeting. I'd like to make a case for why midwives should be allowed to purchase the audiology testing equipment and perform audiology testing on newborns in California to promote the widespread testing of newborns who are born outside of hospital centers.
Thank you.
Ms. Weisner, I'd like to go over the standing agenda items and then read back to you the agenda items that were discussed.
Sure.
Okay. The standing agenda items are the approval of minutes, report from the MAC chair, update on midwifery related legislation, and the program update. I also have the selection of one new MAC member for the vacant public member position, and the presentation on midwife access to audiology equipment and training by Mason Wilson Tenev. Would you also like to include the report from the task force on Medi-Cal related issues?
Yes, please.
Thank you. Okay, and the new items that were discussed, you wanted to add accessibility and sustainability of California midwives? Is that correct?
Yes, please.
Okay, and then did you want discussion on a presentation to the medical board? Is that something?
Yes, yes, please. Thank you.
Okay. And issues faced by California midwives, is that basically in conjunction with accessibility and sustainability of California midwives? Are those together or are those two separate items?
I think they should be two separate items.
Okay.
That's my opinion. Does anyone else have a take on that?
I agree. They should be two separate items for the sake of conversation.
For sure.
Thank you. That's all I have.
I have one more suggested agenda item that would be a presentation on the licensed midwife annual report, specifically critical research flaws in the licensed midwife annual report and opportunities for better data collection for licensed midwives.
Would that be presented by you, Ms. Weisner?
Sure. I'm happy to present. Yeah.
Thank you.
Thank you. Do we have any other agenda items for the next MAC meeting? Or are there any public comments?
Yeah, we can call for public comments again one more time since got a little mixed up with the president report update there too. So anyone wishing to make a additional or request an additional agenda item for an upcoming MAC meeting, please go ahead and use the hand raising feature of the Q&A window. See if anyone queues up here in the next few seconds. Not seeing any questions, Weiser.
Right. Thank you to everyone for attending today. I know that we all appreciate everyone's time here. And it looks like we have finished our business. So this meeting is adjourned. Have a great day.